This is A&P Live Studio. I'm your host. As a registered nurse and an anatomy and physiology instructor for advanced healthcare professionals, I'm here to help make complex topics feel a little more straightforward. Welcome to today's session. Our focus is a really important and potentially life-threatening condition known as serotonin syndrome.
So, to get us started, let's ground our discussion in a clinical scenario. I want you to meet Miss Chen. She's a 70-year-old woman, and she's been brought to the emergency department by her family. They're worried. They say she's become really confused lately and is having these upsetting involuntary muscle spasms. Now, looking at her chart, we see her home medications include paracetamol, that's an SSRI, and quetiapine, which is an atypical antipsychotic. We're going to keep Miss Chen's story in mind as we unpack what's happening to her.
All right, here's our roadmap for today. We're going to start small, at the molecular level, with the normal serotonin synapse. Then, we'll see what happens when that synapse goes into crisis. From there, we'll connect that internal chaos to the symptoms we see in our patients, talk about diagnosis and management, and finally, zoom out to see the impact on the rest of the body.
Okay, let's start at the very beginning. Because to really understand what's gone wrong for Miss Chen, we first have to appreciate the beautiful, elegant balance of a normal serotonin system. This blueprint for how things are supposed to work is absolutely key to understanding the dysfunction.
So what exactly is serotonin? Well, you might see it called a 5-HT, that stands for 5-hydroxytryptamine. It's a neurotransmitter that has a huge job description. It's a major player in regulating everything from our mood and sleep to our appetite and body temperature, and even our muscle tone. It works in both the central and peripheral nervous systems, and you can think of it as a master regulator, keeping so many of our body's functions in balance.
The life of a serotonin molecule is a really tightly controlled cycle. It all starts with the amino acid L-tryptophan. From there, it gets packaged up into these little storage bubbles, or vesicles. When a nerve impulse arrives, those vesicles release the serotonin into the synapse, which is that tiny gap between neurons. It travels across, binds to receptors, and passes its message along. But the signal can't just stay on forever, right? So a special transporter called SERT comes along and pulls it back into the first neuron. And then finally, any leftover serotonin gets broken down by an enzyme called monoamine oxidase, or MAO. It's a clean, efficient system.
Now let's look at what happens when that meticulous system gets thrown completely out of whack. When certain medications interfere with this process, it can unleash what we call a pathophysiological storm, basically a toxic flood of serotonin in the synapse.
And this slide really paints the picture, doesn't it? On the left, you've got your normal synapse, everything's in balance, but on the right, in a toxic synapse, it's just a flood. This is what happens when those cleanup mechanisms we just talked about, the reuptake by SERT or the breakdown by MAO, are blocked or overwhelmed. You end up with way too much serotonin hanging around in the cleft, which leads to massive, relentless overstimulation of the receiving neuron.
So how does this flood actually happen? Well, there are several different drug mechanisms that can cause it. The most common one is inhibiting that reuptake process, and that's exactly what SSRIs, like Miss Chen's paracetamol, are designed to do. But other drugs can inhibit the metabolism, like MAOIs. Some can cause a massive release of serotonin, like amphetamines, and others can directly stimulate the receptors themselves. Now, what's really important to remember is that the most severe, life-threatening cases usually involve a combination of drugs that work through two or more of these pathways at the same time.
So while there are a lot of roads that can lead to this serotonin flood, the final common pathway is always the same. It's all about the excessive stimulation of very specific postsynaptic receptors. Research has really pinpointed two major culprits, the 5-HT1A and the 5-HT2A receptor subtypes. These are the two that are primarily responsible for the clinical signs and symptoms we see.
And this brings us right back to our patient, Ms. Chen, because that molecular chaos we just described, it doesn't just stay microscopic, it explodes into the real world as a very distinct and recognizable set of symptoms, which we classically describe as a clinical triad.
This classic triad is made up of three components: altered mental status, autonomic instability, and neuromuscular hyperactivity. You can think of these as the three main pillars of the diagnosis. And crucially, every single one of them is a direct result of that receptor overstimulation we've been talking about.
So first up is altered mental status. Ms. Chen's confusion is a perfect example of this. Physiologically, this is driven by the overstimulation of those 5-HT1A receptors, particularly in the brainstem. And this symptom can be a whole spectrum. In milder cases, it might just be some anxiety or restlessness.
But as it gets worse, you see the kind of agitation and confusion Ms. Chen is having, and in severe cases, it can progress all the way to delirium or even a coma. The second pillar is autonomic instability. This is where all that extra serotonin starts messing with the autonomic nervous system. You'll see things like a really fast heart rate or tachycardia and blood pressure that's all over the place. Patients are often sweating profusely. We call that diaphoresis, and their pupils will be dilated. But the most dangerous sign here is hyperthermia, a really high body temperature. And there's a key point. This is not a normal fever that's being controlled by the hypothalamus. This is heat being generated by all of that intense, nonstop muscle activity.
And that intense muscle activity brings us to our third and maybe most specific piece of the triad, neuromuscular hyperactivity. This is driven by the overstimulation of those 5-HT2A receptors, especially down in the spinal cord. Clinically, we'll see things like overactive reflexes, hyperreflexia, and muscle rigidity. But the single most important diagnostic sign, the real hallmark, is clonus. That's a rhythmic, involuntary muscle contraction and relaxation. It's exactly what Ms. Chen's family was describing as spasms, and finding it on exam is a huge clue that you're dealing with serotonin syndrome.
Okay, so now that we've connected the dots from the molecules to the symptoms, let's get practical. How do we actually confirm this diagnosis? And more importantly, how does our understanding of the whole process guide how we treat it?
And this is absolutely critical to understand. Unlike so many other conditions we deal with, there is no blood test, no imaging scan, no lab value that will tell you, yes, this is serotonin syndrome. The diagnosis is made entirely at the bedside. It's based on two things. Number one, a history of taking a serotonergic drug, and number two, finding those characteristic symptoms we just went over. This is why having a strong grasp of the clinical picture is so essential.
To help make this clinical diagnosis more objective, we use a tool called the Hunter criteria. Think of it as a decision-making algorithm. First question, is the patient on a serotonergic drug? If yes, you move on. Next, you look for spontaneous clonus. If you see it, boom, diagnosis confirmed. If not, you check for clonus that you can induce plus agitation or sweating. If you got that combo, diagnosis confirmed. And if you still don't have it, you look for the last pair, tremor plus hyperreflexia. Finding any of these combinations basically clinches the diagnosis.
Now, if we look at the data from the FDA's Adverse Event Reporting System, we get a really clear picture of the highest risk combinations. The most common offenders? Combining an SSRI with another type of antidepressant. Right behind that is combining an SSRI with certain opioids, especially drugs like tramadol and fentanyl. The big takeaway here is that polypharmacy, a patient being on multiple medications, is a major risk factor.
So the treatment plan flows perfectly from what we know about the pathophysiology. Job number one, without a doubt, is to stop any and all of the offending medications. You have to remove the fuel from the fire. After that, it's all about supportive care, things like IV fluids and oxygen. We use benzodiazepines to help with the agitation and that intense muscle rigidity. In more severe cases, we might even use a medication called cyproheptadine, which directly blocks those 5-HT2A receptors. And for that dangerous hyperthermia, remember, Tylenol won't work. We have to use aggressive external cooling methods.
All right, let's start to wrap this up. We'll summarize the key points and take a final look at the broader impact of this condition. Because that storm that starts in the synapse, it creates a powerful ripple effect that can be felt throughout the entire body.
You see, while the nervous system is ground zero for this problem, the consequences are truly systemic. The cardiovascular system gets stressed from the high heart rate and swinging blood pressure. The muscular system, with all that intense activity, can actually start to break down, a condition called rhabdomyolysis. This releases a protein called myoglobin into the bloodstream, which can then travel to the kidneys and clog them up, potentially causing acute kidney injury and damaging the urinary system.
So to tie it all together with Ms. Chen's story, the combination of her medications caused that flood of serotonin in her synapses. This went on to overstimulate her 5-HT1A and 5-H2A receptors, which in turn directly caused her confusion and muscle spasms. It's a clear chain of events. And that's why her treatment is all about stopping those meds and managing the downstream effects of that receptor overstimulation.
This leaves us with a really important question for all of us as current and future clinicians. We know polypharmacy is becoming more and more common. So I want you to think about this. How can we use this deep understanding of pathophysiology to get ahead of the problem, to anticipate and even prevent these molecular storms before they ever have a chance to begin?
Please remember, this session is for educational purposes only and is not a substitute for professional medical advice. Always be sure to consult with a qualified healthcare provider for any medical concerns. Stay patho-curious, and I'll see you in the next session.